Hi, welcome to the King's Health Partners Haematology podcast series called KHP HaemPearls. I'm Dipti Ryder, Haematology Consultant at Guy's and St Thomas's Hospital, and I'm delighted to be here again with you. Today's podcast will focus on neutropenia. I'm very glad to introduce my colleague, Dr. Musab Omar, who's a consultant haematologist at King's College Hospital and based at Princess Royal University Hospitals. And we'll be talking through some common queries that we have from primary care colleagues around neutropenia. So thank you for joining me today, Ms. Sab. I'll go straight on to the first question and we'll see. So I guess the common question is, what is neutropenia and how is it typically defined in terms of lab values and clinical significance?
First, thank you for inviting me to this podcast. So neutropenia is a condition which is usually characterized by an abnormally low neutrophil count. And as neutrophils are the most abundant cell in our white blood cells, and they also important in fighting bacterial and fungal infection, it's important to recognize when this condition and how we manage it. There are various degrees of severity depending on the actual neutrophil numbers. As hematologists, we are less concerned with mild neutropenia, which is usually indicated by a neutrophil count above 1 and between 1 and 1.5. And in those patients, we would recommend monitoring and looking for an associated causes. However, with moderate and more severe neutropenia, then discussion with the hematologist through advice and guidance, or even picking up the telephone if the neutrophils are concerning low below 0.5, might be helpful to try and identify those patients who might benefit from an urgent hematological review.
Thank you very much. Because there's a huge range of the normal range, and then there's a balance into how below normal is really significant. So thank you for outlining that. So what are the common causes of neutropenia? And how can GPs differentiate it between those that might be benign and those that might be serious etiologies?
So first, just to try and give a brief, what we try and, when I see a patient in clinic, to try and identify which patient who I need to be concerned about. So patients who are more stable, so who had neutrophil count, when I look back like 5 years ago, the same neutrophil count that's stable, I'm usually less concerned about these patients. Patients who are asymptomatic with no history of recurrent infections. And then patient with a, like we said, mild or even neutrophils usually above 0.7, 0.8, for example, from an ethnic African background, which might suggest a more benign condition. And after doing general history and examination with no obvious other concerning findings of malignancy, that's usually I would be more reassured in those patients, yeah.
So again, it's looking at the clinical picture, isn't it? Like with everything that we do, is the context of the clinical examination, the history, and the clinical picture.
That's
to
right,
then embed. Yeah.
And then initial, like the important thing we do in the lab initially is looking at the blood counts, making sure the other blood counts like the platelets and the hemoglobins are also normal. If there is associated cytopenia, or when we get a reported blood film that's also showing abnormal cells, then we, for example, blasts, which suggest an abnormal bone marrow findings. So in those patients where there are other associated problems or other findings, like if you find an enlarged lymph node in examination or hepatosplenomegaly, then those definitely were patients who would need a hematological review.
Yeah. Excellent, thank you. In terms of medications and other common causes like infections, what would you inform the GPs to look out for and how identify these?
I think probably a lot of GPs are aware of the common medication that can cause neutropenia. For example, psychotropic medication like clozapine, and also, for example, medications such as antibiotics such as chloramphenicol, sometimes some beta-lactams, and antiepileptics, carbamazepine and valproate. And recognizing that these medication can cause neutropenia, and then adhering to our monitoring guidelines, as they have specific monitoring guidelines to recognize this patient, and then adjusting treatment as needed. Sitting with the patient and getting history of infections and recognizing any patient with neutropenia, especially very severe neutropenia below 0.5 with a fever. These are medical emergency patient and needs urgent attention. Asymptomatic patient who are otherwise well, then these can be managed in the community with a discussion with the special interested specialties.
And I guess I'm thinking a little bit wider about infections like HIV and hepatitis and viral infections that are treated quite well in the community will have an associated neutropenia. It comes back to getting the whole picture, doesn't it?
That's true.
With
I
those.
just had a patient actually a month ago who come in with neutropenia, moderate neutropenia, and it was because of an active HIV infection. Yeah.
Excellent, thank you.
Mm.
So the workup for neutropenia, you've already mentioned the clinical features that would raise concern. Is there anything else? So what would be, when we get the referrals with neutropenia, we kind of have a list of investigations. You mentioned blood film, possibly is what we do. Are there any others that you think need to be part of an initial workup from a primary care point of view?
I think as an initial blood test, I would expect it to be done. So a normal blood count, a blood film, and a check for B12 and folate deficiency and for any evidence of nutritional deficiency, because these can be easily reversible. Also, maybe then depending on your history and examination, then that you will be guided if there is any possible infection. So checking for HIV, hepatitis, urine cultures, stool cultures, or any markers of inflammation, for example, CRP. If a patient presents with any signs of an autoimmune disease, then doing the initial autoimmune screen can be quite helpful in those patients. And and then maybe an ultrasound might be helpful sometime if there is history of liver cirrhosis or any other rheumatoid arthritis, and you're thinking of enlarged spleen as a possible cause. Yeah.
Yeah, and I have to admit, I tend to do an autoimmune screen fairly early up, even if there aren't any symptoms, because they can evolve and be
That's true.
silent.
Yeah.
So just to be aware that that is, because you can pick up quite evolving autoimmune diseases, so the referral or the management of that patient is dealt with slightly earlier, which would be great. Okay, so coming back to chronic neutropenia, we will have a lot of patients who have chronic neutropenia, and they're managed in an outpatient setting, or perhaps even discharged from hematology to a general practitioner. What's your advice about monitoring these patients and things about infection? What sort of life adjustments? How would you advise that patient so that the GP also has that same advice?
I think the GP play a critical role really in the maintaining communication with the hematologist and also with the patient. They are usually the first point of contact and alerting specialties of any deterioration or problems. I think for patients who are stable and discharged from clinic, this usually would, if any signs of infection in the future, that means this patient will need earlier attention. Depending on the degree of the neutropenia, usually patient with severe neutropenia would be monitored in clinic, and discharged patient usually either moderate or mild neutropenia, and these are stable patient. If they in the future they develop any other cytopenias, then this would warrant rediscussion. But maintaining a good link with the patient to be able to reassure them and so that they feel that they can report any symptoms or if they have any question, I think is the most important thing.
Yeah, and I guess an early kind of, I know it's very difficult to try and predict infections, but having a high threshold to make sure that patients who have this low threshold of a neutropenia are seen a little bit sooner. I know we advise that for our patients anyway, in terms of if they get temperatures, they need to seek help.
And I think vaccination is an important part of
Yeah.
that, just making sure these patients are up to date with their vaccination, especially pneumococcus and influenza. And if they're traveling, just to make sure they do know that to contact their health provider for advice about depending on where they're traveling. Yeah.
No, that's a good point. I hadn't actually thought about that myself. So I guess moving on towards the end, we've got the thresholds for neutropenia. You've done the kind of thresholds in terms of the laboratory and where to look out for. So thank you, because it is a common problem. I guess one of the things is with our population at the moment, we have the ethnic neutropenia. Can you tell us how that's identified, implications, what your thoughts are, please?
I think the most important thing to recognize, this is a benign condition. It's caused by a gene polymorphism, which is called the Duffy gene. It's found in areas usually endemic for malaria because it's presumed this gene have a protective effect from that. And the most important thing, this patient who needs to live their life normally, this important to educate patient about the condition and to recognize it for what it is, to avoid over investigation and causing anxiety. Usually patient will have mild neutropenia, meaning neutrophils above 1. Patient with moderate neutropenia might require a hematological review to exclude other causes. and a health review just with general normal physical exam and history usually is enough to identify this patient as long as they're asymptomatic and from the correct ethnicities. I think the most important point is to recognize this so as not to prevent access to certain treatments for this patient, and so that they can have individualized target and management plan if they need access to specialized immunosuppressive or drugs or medications.
I think that's really vital, actually, for the patient to know that's a diagnosis and be aware of their baseline counts when they're well. It's kind of patient information that's really useful. And then, of course, patients will develop other illnesses. So knowing their baseline and making sure that they're aware of it and clinicians are aware of it will enable us to treat them correctly and appropriately as time moves on. I think that brings us to our wrap up of a podcast, would you believe, on neutropenia today. Thank you so much, Mr. for joining us, and to our audience for listening. We hope you learned something along the way with us. Please spread the word to your colleagues and share the podcast. We'd really appreciate it if you leave a review and let us know if there are any other topics you'd like for us to focus on in the future. So thanks again, Musab, and this is our Neutropenia One finished.
Thank you for the invite. Thanks.